All right, looks like we are live. Hey, folks, thank you for joining for this month's medical talk for the webinar series. Appreciate you all being here. 100 people so far is wonderful. We have the pleasure today of introducing Dr. Luke Roberts, who's one of our OBGYN attendings here at Maine Med. I had the pleasure of first meeting Luke when I was learning in my own little L&D rotation as a little intern, and Luke showed me the way, and now he gets to be here to help all of us kind of go through some of these higher acuity, lower frequency OB emergencies and some of the pre-hospital management. So without further ado, Luke, I'll hand it over to you, and yeah, we'll help monitor both the Q&A and the chat feature. I know some work for some folks, some work for the other. So put in questions as we go. We'll pass them on to Luke, and otherwise I'll pass it on over to him.
All right. Thank you for that intro, Joe. I can remember fondly your time with us on labor and delivery. I'm going to go ahead and try and see if I can share my screen here. So bear with me for just a moment. Always a bit of a challenge. All right. Are you guys able to see this title slide here?
We are. Looks good.
Okay, perfect. And if I advance, you're seeing that okay?
Looks good.
All right, perfect. And not seeing the presenter view, are you? You're not seeing all my little cheat notes?
Nope, just the slides.
Okay, great. I don't want to spoil any fun surprises. So as Joe mentioned, I'm an OBGYN physician over at Maine Med. I am here to talk to you guys as part of your OB emergency kind of series. And today we're going to focus on two topics that are, fortunately not extremely common, or at least eclampsia is not super common. We're going to talk about hemorrhage in more detail there, but very high acuity. And so being prepared for these situations can really make a dramatic impact on patient outcomes pre-hospital arrival. I don't have any disclosures or financial conflicts of interest to report, but if anyone has anything that they'd like to pay me for, please, by all means. Objectives today, we're going to try and recognize and assess the signs, symptoms, risk factors associated with both eclampsia and postpartum hemorrhage in the pre-hospital setting. We're going to try and apply evidence-based EMS interventions for managing seizures in pregnancy and controlling postpartum hemorrhage, focusing on things like airway considerations, seizure management, uterine massage, appropriate medication use. We're going to work on coordinating safe, timely transport and communication to the receiving obstetric teams. These are two things that can, kill young, otherwise healthy patients really quickly. So definitely topics that I want you guys to feel comfortable with managing. Before we dive into them, I'm just going to give a really brief kind of reminder about some of the physiologic changes that we see in pregnancy, because what's normal for many patients may not be normal for our pregnant or recently pregnant patients. So a couple of the important cardiovascular changes that we see in pregnancy: patients' cardiac output increases pretty notably by about 30 to 50%. Fun little math part of this session here, just as a reminder that cardiac output is a metric of your stroke volume and your heart rate. And so both of these things are going to increase, mainly due to the demands of the uteroplacental circulation. So in order to, again, meet that increased cardiac output, heart rate is going to increase in pregnancy on average about 10 to 20 beats per minute. So if someone's normal resting heart rate is around 70, a resting heart rate in pregnancy of 90 to 100 beats a minute is actually perfectly normal. Stroke volume similarly is going to increase by about 30%. You're going to hear me talk a couple times throughout this presentation about maternal positioning during our initial assessment. And cardiac output in pregnancy is exquisitely sensitive to maternal positioning. By laying directly supine, the gravid uterus, whether it's a patient is still pregnant or recently delivered, the uterus is still quite enlarged, has the ability to really compress the aortocaval structures. And so an important aspect of initial management is going to be putting a patient into a left lateral decubitus position to try and relieve some of that compression of the IVC. Another important cardiovascular change is the change in systemic vascular resistance. So that drops about 20%, which is why despite this increased blood volume and despite this increased cardiac output, patients' blood pressures remain low and are often a little bit lower in pregnancy than they are outside of pregnancy. A couple relevant and important hematologic changes in pregnancy are an increased total circulating blood volume. This is manifested in both an increase in plasma volume, which increases by about 50% in a pregnant patient. And that increase is a little bit higher than the red blood cell mass, which does increase, though less so than the plasma. So that results in a relative dilutional anemia. So even though a patient has more red blood cells and has a higher oxygen carrying capacity, their baseline hemoglobin, baseline hematocrit levels are a little bit lower in pregnancy, so we tolerate a slightly different threshold. Other important changes, there's an increase in procoagulation factors. So most of this is driven by the hormonal changes of pregnancy and predominantly by estrogen, which increases the circulating clotting factors and decreases some of the circulating anticoagulant factors. All of these are just the body's natural adaptations to prevent a postpartum hemorrhage, right? One of the unwanted consequences, and not overly relevant to this talk, but still just a nice reminder, is that these things are going to also be the reason that venous thromboembolism and DVT are more common in pregnancy. And so those increase by about 5 to 10 times during pregnancy because of these changes. All right, so there's your kind of boring physiology intro, but we're going to kind of start with just a little bit of a case presentation, case introduction that I is going to get you guys thinking about your comfort with these situations and these scenarios right now. Because we have such a robust and great attendance, I'm not going to open up to have everyone chime in and give some answers, but I encourage you to think critically as you're going through these cases. Feel free to jot some notes down. We'll come back to this at the end, just to kind of tie in what we've learned and what we've discussed about how we may address or approach this case differently. So imagine you get a call from dispatch. You get a 28-year-old female just delivered at home who's bleeding heavily, and you're 8 minutes out. So what are some things that you're thinking about on the way? And what is some equipment and what are some medications that you're preparing? I'm going to try and give some dramatic pauses, but it's not a skill of mine. On arrival, you notice that the patient is pale, she's anxious, she's lying on the bathroom floor. There's a large amount of blood on towels, and her partner is there with her, says that she delivered about 20 minutes ago. What are some of your first priorities when you walk in and see the situation and assess the situation? You get an initial set of vitals on this patient who is tachycardic, she's hypotensive, she's tachypnic, and she's noted to be dizzy and weak. So what in this situation is your working diagnosis? In your initial assessment, in your initial exam of the patient, you note ongoing bleeding with clots. The uterus feels soft and boggy. What's an intervention that you can do here that's going to immediately change this physiology? After you do some of those initial interventions, you notice that bleeding slightly improves, but it's still ongoing. And so what are some of the next steps that you're going to perform en route to the hospital with this patient? All right. Thank you for bearing with me through those case presentations, or that case presentation, I should say. So first topic we're going to talk about here, obviously, is going to be postpartum hemorrhage. So postpartum hemorrhage is the leading cause of maternal mortality worldwide. It accounts for up to 25% of maternal mortality cases. We define postpartum hemorrhage in the obstetric world as blood loss greater than 1 liter, so 1,000 milliliters, or blood loss with signs of hypovolemia. Historically, it used to be blood loss greater than 500 milliliters after a vaginal delivery and 1,000 liters after a C-section, but that framework has recently changed, and so now it's exclusively just blood loss over 1,000 liters, or again, blood loss with any signs of hypovolemia. Can further be broken down into primary and secondary postpartum hemorrhage. So primary occurs within 24 hours of delivery, and secondary occurs greater than 24 hours after the delivery and up to 6 weeks postpartum. Here's one of the important things I just want to make sure that I mention. We're talking about some uncommon presentations of postpartum hemorrhage, but postpartum hemorrhage itself is not uncommon. It occurs in about 5 to 10% of births. One of the most important things with respect to postpartum hemorrhage is early detection. And early detection truly is the key to improving outcomes. One of the things I really want to stress is that some of those signs of hypovolemia, things like tachycardia, hypotension, those really only are going to present once a patient's lost about a quarter of their blood volume. And so we're thinking closer to 1.5 liters at that point. And so, a patient has already met that threshold for a postpartum hemorrhage, often long before we see those clinical signs of hypovolemia. So when you start to see those things, you really need to be making immediate preparations for getting a patient, where they need to be to the hospital setting as fast as possible, and making sure that you give a good, presentation and heads up of what has happened to that point, preparing for a blood transfusion, preparing, the team for arrival as soon as you're there. When thinking about a postpartum hemorrhage, this is a really helpful, quick mnemonic just to remind yourself, what am I dealing with and why is this happening, right? So the 4 T's is something that we teach med students, residents, colleagues. This is the kind of bread and butter for what is the cause, why is this postpartum hemorrhage happening? And so when you think about your 4 T's, what I want you to think about is tone, trauma, tissue, and thrombin. So when we think about tone, we're thinking about uterine atony, and that's far and away the most common cause of postpartum hemorrhage. So uterine atony accounts for about 70 to 80% of all postpartum hemorrhages. Trauma accounts for the next 20%. We're thinking about lacerations, hematomas, uterine rupture. Tissue, we're thinking about retained placental tissue. We're thinking about retained blood product or blood clot within the uterus that's preventing it from contracting down. And then thrombin, we're thinking about coagulopathies, disseminated intravascular coagulopathy. It's often a combination of these things. It's rarely in isolation a single cause. And one can often occur downstream after something's happened. So if someone has profound uterine atony and has a significant blood loss, that may ultimately result in a coagulopathy downstream where you have a postpartum hemorrhage that continues for a different etiology. So always kind of constantly reassessing, what do I think is going on and how can we address that? So we're going to start with just talking again about tone. And so uterine atony, again, is being the most common cause, the most common etiology for a postpartum hemorrhage. And it causes about 70 to 80% of those postpartum hemorrhages. The most important initial assessment, initial treatment that you should be doing is a fundal massage or a bimanual compression. Bimanual compression is often, something that an obstetric provider or an experienced provider is going to be performing because that does involve a vaginal exam as part of that procedure. But a fundal massage, that is something that is critical to performing early on, immediately in a postpartum hemorrhage. Even if, atony is not ultimately deemed to be the cause, right? You're going to feel a rock hard structure right around someone's belly button. And that may say, okay, great, my tone is good. So now I need to start thinking about some of my other causes, some of my other T's. But oftentimes you're not really going to feel a lot. You're going to just kind of feel a boggy, kind of soft, squishy, flat uterus. And so the fundal massage and that bimanual compression is going to be the most important first assessment with a postpartum hemorrhage. It's one of the few times in medicine where your hands physically can be the immediate change in physiology, right? Pushing on someone's abdomen, performing that fundal massage compresses the uterus. That mechanical compression is going to directly close some of the vessels that are within the uterus. It's also going to stimulate some hormonal and prostaglandin release that are going to further help to contract the uterus and prevent bleeding. So your hands directly are completely changing the physiology that's taking place and causing this excess bleeding. So it's a really critical, important, unique, valuable tool that you have in your tool belt. There's some uterotonic medications, so meds that are going to help the uterus contract down and help address this atony. Kind of the mainstay of treatment is oxytocin. Sometimes is available in the pre-hospital setting, other times is not. Often in the pre-hospital setting, we're looking at an intramuscular injection of 10 international units of oxytocin. And similarly, in a patient who arrives to the hospital and precipitously has a baby before we establish any kind of IV access, we use intramuscular oxytocin fairly regularly. But the mainstay is often a prolonged infusion once patients are in the hospital. There are a few other medications that also function to improve uterine tone, but most of these are not available in the pre-hospital setting, but I just figured I would include them here and mention them so you're familiar with the names and policy and protocol changes where these do become more readily available. There are a few other medications that can help with this, things like methergin, carboprost, and misoprostol. Once a patient's in the hospital, there are also a few other kind of physical tools that we have from a uterine atony standpoint. So certain things like uterine tamponade balloons or a Bakri balloon you may have heard the name of. And there's some newer devices that are a vacuum-induced hemorrhage control. It's essentially a suction vacuum device that goes inside of the uterus. So instead of compressing from the outside, it actually squeezes and pulls the uterus in from the inside. But same concept as what you're doing with a fundal massage, that compression of the uterus itself and the uterine muscle is going to mechanically compress and close those vessels that are causing all this bleeding. Thinking down the line now to our other T's from a postpartum hemorrhage standpoint, we're going to think about trauma. And so trauma, we think about cervical or vaginal lacerations, hematomas, uterine rupture, or uterine inversion. Tissue, we think about, again, retained placental tissue or retained blood clot. Here it's important to, just be aware and think about on arrival, if the patient's placenta has not delivered yet, you do not want to perform a fundal massage if the placenta is still in place. And you don't want to forcibly try and remove the placenta. I believe that some some providers, depending on the level of certification and training, do have the ability to help with delivery of the placenta. And with that, what you're doing is just this kind of gentle, steady downward traction on the umbilical cord. But you're maintaining what we call suprapubic counterpressure. So right behind the pubic bone, you're actually putting pressure down in to hold the uterus up in place, as opposed to pushing the uterus from the top. If you're just really pulling on the umbilical cord, one, it can avulse and tear off, and then we have to go in and kind of manually remove the placenta by hand. Or if the placenta is not ready to separate and you're really pulling too hard, you can invert the uterus, essentially turn the uterus inside out, which can cause a massive acute hemorrhage. And so just something that you really want to be cognizant of and really cautious with in terms of the delivery of the placenta. And then lastly, again, is thrombin or coagulation defects. And so that is going to be something that's corrected with blood product replacement and factor products. So some common errors or common things that we see with postpartum hemorrhage where we see things go wrong. And I just want to kind of spend a quick minute on this, because this is, often when we see things that don't have, if we see a poor outcome, we can often trace it back to, where did things fall apart along the way? One of the most common errors, and a lot of these things happen in the inpatient setting too. And so I want to, just stress the importance. This is something that we're thinking about even in the hospital, within hospital deliveries. And one of the most common is just failure to recognize the severity of the bleeding, right? This kind of, it's just postpartum bleeding, this is normal, everybody bleeds after delivery mentality often leads to a really dramatic underestimation of the true blood loss that takes place after delivery. One of the most common errors is just not performing that fundal massage, right? Again, that is your chance to put your hands on a patient and really, really change the physiology and change the outcome. And it's an aggressive push right on top of the uterine fundus. Sometimes the time at the scene gets too long, and we're not quite as in as big of a rush as we need to be in terms of getting the patient transported to the hospital, and then under resuscitating the patient. So really got to focus on once we establish IV access, getting a patient volume replaced as quickly as possible. People don't realize how fast these patients can crash, right? And so we got to really be on top of this and start acting quickly when we recognize this situation. When patients are in the hospital, right, we're throwing a whole OB hemorrhage protocol. We have massive transfusion protocols. We have 15 nurses. We have someone running to get medication, someone running to get blood products. We have anesthesiologists. We have surgeons. We have all these providers who are here and doing this. In the field, you have like 2 people and 4 things, right? And so the question is not, do you know the 15 things that we can do when we're in the hospital? It's, do you know those 4 things and can you do them immediately? And so I made a couple of cheat sheets, and I'm happy to share these slides with Eric and Joe, and they can disseminate these out to you all. These are kind of individually helpful to have, but what I want you to do is just make sure you recognize, think, and act. So first thing, recognize that heavy bleeding and potentially shock is postpartum hemorrhage. Think that and assume that this is uterine atony until proven otherwise, and then act. So I want you to act from a fundal massage standpoint. Give any kind of uterotonics that you have, and then TXA, which I realized that I think fell off my slide from a slide earlier. But TXA is a antifibrinolytic, so it helps blood clot and helps dramatically reduce blood loss. That is something that I know is readily available in the majority of transport settings, and that is something that has been proven to reduce mortality and morbidity with postpartum hemorrhage, and is absolutely one of the first medications that you should be going to grab, and then transporting the patient. So the whole name of the game again is that fundal massage, establish IV access, give TXA or Pitocin and fluids, and move. Right? You don't need to know these 10 causes. You just need to do these 4 things fast. So thinking back to our initial case, let's kind of reflect on what were our initial thoughts. Did we have the right answers in this setting? Did we have them, but we didn't get there quick enough? Right. So let's think back to what these situations were. Right. So we have that 28-year-old patient you're going to see, just delivered, having heavy bleeding. What are those things you're thinking about on the way? What equipment? What meds are you preparing? Right. And so the big point here is before you even arrive, this should already be on your radar. This whole situation, you should be thinking postpartum hemorrhage, potential hemorrhagic shock. Right? What are your first priorities when you get there? What's your working diagnosis? Right? You get there, your initial assessment should still be your primary survey of the scene. Should be recognizing the severity of what's going on and not underestimating the severity of the amount of bleeding that a patient can be having. And don't try not to get distracted by the environment. Right? This is something often you get there, someone had a baby 10 minutes ago at home that was not part of their delivery plan, presumably. And there's going to be a baby crying. There's going to be family, friends, someone who's chaos all around things. Try not to get distracted by the environment. Focus on the patient at hand and the situation at hand. And then lastly, what intervention can you do that's going to change this physiology, and what are your next steps en route, right? I know I've said this a million times, but I'm going to keep saying it. This is one of those few times in medicine your hands can truly change physiology. So right away, I want you to be thinking about fundal massage, fundal assessment, IV access, fluids, TXA, frequent reassessment, or early hospital notification. So those are going to be the things that are going to help improve outcomes until the patient's in the hospital. All right. We're going to shake things up and switch topics here. Any questions at the moment, Eric or Joe?
Nothing has come through so far.
Okay, perfect. Well, in the interest of time, I'll just keep chugging along. So our second case here, we've got a 32-year-old female. You're calling from dispatch. This 32-year-old female, seizure at home, who recently gave birth, and you're 6 minutes out. What diagnosis are you considering? What equipment, what meds are you preparing? You arrive, the patient's postictal on the couch. Family member reports that the patient had a severe headache earlier in the day and that she delivered 5 days ago. Anything in particular here standing out? The patient's initial vitals, she's a bit tachycardic and she's hypertensive. She's confused, and then she starts seizing again. What's your working diagnosis? What's your first line treatment? What are you reaching to give the patient? During transport, the seizure stops after you give this patient medication, and she's somnolent but breathing. What are your priorities now? How aggressive are you being with respect to blood pressure? All right, so here we're obviously going to dive into eclampsia. I know you guys already had a talk in the fall, I believe Joe said, about hypertension in pregnancy and some of the hypertensive disorders. So I'm not going to go into grave detail on this specifically, but just as a brief reminder summary, hypertensive disorders of pregnancy are a spectrum. And so there's, pre-existing or chronic hypertension. That's, a patient who has high blood pressure prior to even getting pregnant. They can still subsequently develop some of the later complications. There's gestational hypertension, which is just high blood pressure in pregnancy. Never had it outside of it, but all of a sudden developed high blood pressure during pregnancy. And then there's preeclampsia, which is essentially that same high blood pressure, but they're also peeing out some extra protein. And then there's a more severe form of preeclampsia, which is all of these same things, but then we see more severely high blood pressures. We see, a constellation of certain symptoms that would meet that criteria, and then certain lab findings for that. Then there's even more severe forms of this, things like HELP syndrome, and then eclampsia. I think the name itself, highlights that this is a spectrum of disease and a progression, but I think it implies that there's this kind of natural linear progression that, if we do nothing, every patient's going to eventually become eclamptic and seize. The reality is actually not quite that. So in patients who have the kind of less severe, just normal preeclampsia, not with any of those severe features, if we did nothing, if we did not treat those patients at all, only about 2% of those patients are going to go on to develop an eclamptic seizure. And of those more severe types, so that severe preeclampsia, if we did nothing, only about 4% of those patients are going to go on to develop an eclamptic seizure. If we kind of give the standard of care treatment, which we're going to get into in a second, that cuts both of the rate of eclamptic seizures in half, but it doesn't eliminate them altogether. So why we care? Again, this is a huge cause of maternal mortality worldwide. So about 16% of all maternal deaths are caused by hypertensive disorders of pregnancy. And eclampsia itself is defined as new onset tonic-clonic, focal, or multifocal seizures in the absence of another causative condition. About 80% of patients before an eclamptic seizure are going to show some signs of cerebral irritation. So when we're thinking about those, we think about those severe occipital or frontal headaches, blurry vision, photophobia, so spots, flashes in your vision, light sensitivities, altered mental status, and hyperreflexia. But this also can occur without any of the signs of preeclampsia. And eclamptic seizures can even happen in patients who don't even have preeclampsia. In patients who have normal blood pressures and don't have any of the lab evidence of preeclampsia, sometimes those patients can still develop an eclamptic seizure. So what causes preeclampsia? Why does this happen, right? The long story short, we don't really know yet. There are increased angiogenic factors and this angiogenic imbalance. There's chronic uteral placental ischemia. There's this idea that very low density lipoprotein toxicity. There's some immune maladaptation. There's increased trophoblastic apoptosis or necrosis and genetic imprinting. All these things to say, we don't really know. It's likely a combination of some of these things. But what does it cause? What happens with it, right? And so the whole idea is that there's this intense vascular vasospasm that is going to result in the downstream effects of preeclampsia and ultimately eclampsia. The headaches themselves are often evidence of this elevated cerebral perfusion pressure, cerebral and brain edema, and this hypertensive encephalopathy. These patients lack the intravascular hypervolemia that we usually see in pregnancy. So again, that overall circulating blood volume is increased in pregnancy when we're thinking back to the beginning of those normal physiologic changes. Patients with preeclampsia often lack that, which seems counterintuitive because a lot of the symptoms, a lot of the things that we see, we're thinking about excess fluid and excess volume, right? But in patients with preeclampsia, they actually have increased capillary leakage and a decreased oncotic pressure intravascularly because they're peeing out so much of that extra protein. And so counterintuitively, if you give these patients aggressive fluid therapy because they're intravascularly dry, it's ultimately going to result in some downstream consequences. That's going to increase their pulmonary capillary wedge pressure. It's going to increase their risk of pulmonary edema and cerebral edema. And so you need to be really cautious and cognizant about fluid management with these patients. So the mainstay of treatment. So what are we going to use in a patient who has an eclamptic seizure? Magnesium, magnesium, magnesium. Okay, the first line treatment therapy for preeclampsia and eclampsia is magnesium. It works better than benzodiazepines. It works better than phenytoin. There are some alternatives, right? But the first line, the best treatment is magnesium. There are very few true contraindications to magnesium, but myasthenia gravis is always a fun one to show off to your friends at trivia night. And other things like renal failure, heart disease. The magnesium itself is completely renally excreted, so it's all cleared by the kidneys. And so that's why in a patient with severe renal disease, you need to be very cautious about magnesium because magnesium toxicity can be wrought with consequences. So I put just a table of the kind of target therapeutic levels. This is not something that you're going to be measuring in the pre-hospital setting, but in a patient who is going to be who ends up getting far too much magnesium, these are things that you could potentially see. The magnesium itself, the way that it works, again, is to try and prevent that vasospasm and improve that cerebral blood flow. So it's a cerebral vasodilator, which helps reduce brain edema, helps draw some of that fluid back into the intravascular space, and it reduces neural excitability. So it inhibits certain brain NMDA receptors that overall reduce the neuroexcitability and acts as an anticonvulsant in that sense. In terms of your dosing, so most commonly what you're going to do in a patient who does not have any IV access and has an eclamptic seizure is you're going to give that patient a 10-gram dose of intramuscular magnesium. And so that needs to be given actually as 2 distinct injections. The solution itself is a 50% solution, so there's about 0.5 gram of magnesium per milliliter. And so for each 5-gram injection is 10 milliliters. So there are often questions about, why the heck do we have to give this as 2 shots? Unfortunately, it just is not able to be constituted in a way that's at a higher concentration to give that, immediate intramuscular dosing any quicker. So unfortunately, it's a huge injection, usually 1 in each glute. And so, 10 milliliter volume in each glute. In terms of your management, right, first thing you should be thinking about when someone has an eclamptic seizure is to manage their airway. Immobilize the spine if it's indicated, follow any head trauma protocols if that's indicated, and then focus on that left lateral positioning. So in a patient, who's having a seizure and does not have that same control of their body, you're going to need to turn them onto their left side, both from an aortic cable compression standpoint, but also thinking about their aspiration risk. You're going to want to do any kind of cardiac monitoring that you have access to, and work on establishing IV access. You still want to get a finger stick glucose because a hypoglycemic seizure is still possible in these patients, and you're going to want to give your magnesium. I know it's titled 1, 2, 3, 4, 5 here, but I want you to be thinking about these things simultaneously and really be thinking about magnesium early on. This here is just a workflow kind of diagram of what we use in the hospital for management of an eclamptic seizure. Obviously, some of these things are not quite as relevant in the pre-hospital setting. The next slide, I actually have just kind of a cut of the specific, eclampsia management protocol that exists in the EMS provider protocols. So first thing, again, is going to be just make sure that you get all the folks you need to kind of help address and help manage this, get vital signs, work on that airway, right? Make sure that the patient has a secure, stable airway. Think about that patient's circulation, put them onto that left lateral decubitus positioning, and make sure that we're maintaining IV access. In terms of seizure control, if a patient has IV access, we are going to give an initial 6-gram magnesium bolus, and we're going to give that over 20 minutes. But if they don't have IV access, which is often the case in someone who arrives even to the hospital acutely with an eclamptic seizure, or when you're addressing an eclamptic seizure in the field, you're going to immediately give an intramuscular injection. So that's that 50% solution, 5 grams in each buttock. If someone is already on magnesium, we essentially just give an additional magnesium bolus dose. So, this could happen potentially in transport of a patient from one facility to the next. And then they're going to stay on a maintenance dose. The vast majority of eclamptic seizures are self-limited. So what we're doing in this setting is actually not trying to arrest or abort the current seizure that the patient is having, but we're trying to prevent recurrent convulsions. If a patient truly has contraindications to magnesium, again, thinking back to that myasthenia gravis, pulmonary edema, renal failure, severe cardiac disease, that's when you're going to think about your benzodiazepines or your phenytoin. This here is, again, just a kind of cut shot from the protocols that you all use specifically. And so this is within the seizure portion of your protocols. And so this is for patients who are, who are visibly pregnant or who are within 6 weeks of postpartum and who are seizing or who are postictal. The protocol that you all have is to give magnesium as a 4-gram bolus over 15 minutes. And if you don't have IV access and the patient is still actively seizing or has recurrent seizure, then you're going to give magnesium sulfate as an 8-gram intramuscular injection, so 4 grams in each buttock. The dosing here is a little bit different, and so just as always, obviously follow the protocol that you guys have and are given. The true, best recommended and most therapeutic dosing strategy for magnesium is still up for debate. And so where, depending where you're looking, you'll see 8 versus 10 grams, you'll see 4 versus 6 grams in terms of your initial dosing. So nothing about this is incorrect or inaccurate. It's just a little different than what we do in the in-hospital setting. If a patient, if this is successful, the patient's seizing is stopped and the patient is postictal, then you're going to start that infusion. If it continues, you're going to give an additional bolus dose. And then again, if it stops, start that infusion. If they continue to seize despite giving the initial higher dose of magnesium, that's when you're going to start to turn to your benzodiazepines. So here, again, some common errors that we see with eclamptic seizures is missing the postpartum context altogether, right? And sometimes in a patient who's just found down, you may not know this. They're increasingly commonly, you'll see patients who are recently delivered in postpartum wearing the orange bracelets that are given to them in the hospital to signify that they're in the peripartum window. But sometimes you just don't have that information. But that is a critical step and a critical thing to be aware of if the patient, it does have someone with them to report that they recently were pregnant. And so just remembering that pregnancy, postpartum, seizure is eclampsia until proven otherwise. So making sure that we're not treating this as a primary seizure disorder, right? And then a common error that we see is not giving magnesium because of that. We also want to be cautious about over-sedation, right? So again, if we're not jumping right to our magnesium and we're just loading a patient up with benzos, we run the risk of over-sedating them and having complications from that. Here's a kind of similar cheat sheet for things to think about with respect to eclampsia. And so similarly, I want you to recognize that seizure plus hypertension plus pregnant or recently pregnant, think eclampsia until proven otherwise. And then you got to act, and you got to act fast with magnesium, maintaining patient's airway, and transporting quickly. So thinking back to the case that we had when we first started to talk about the eclampsia here, we had that 32-year-old patient recently delivered who was seizing at home. You're on the way, right? What diagnosis are you considering? What equipment and what meds are you preparing? Right here, I want eclampsia to be at the top 1 or 2 of your differential immediately, right? I don't want you thinking epilepsy. I don't want you thinking stroke. I want you to obviously think about those things, but I want eclampsia to be the top 1 or 2 of your diagnosis immediately in the patient, right? And I want you to start to think about having magnesium at the ready. What stood out about the initial assessment on this patient, right? The key point here is the postpartum and the headache, right? Postpartum still counts. When we think about preeclampsia, being postpartum still is a risk for preeclampsia and eclampsia. And this is often a huge mispoint that people think, well, once they're delivered, once we're no longer pregnant, once the baby's out, preeclampsia and eclampsia, that's not a thing. So this is just an epileptic seizure. But it still counts. This physiology is still there. Things do not kind of return to pre-pregnancy and normal until at least about 6 weeks postpartum. And so being immediately postpartum still counts. If you hear a patient who's got a severe unrelenting headache and is hypertensive and is postpartum, think preeclampsia, be concerned and be on high alert for an eclamptic seizure. Okay, so what's your working diagnosis? Obviously, eclampsia here in this setting. And what's your first line treatment? Right? Magnesium is not just one of your options. Magnesium is the treatment. Right? Benzos are your backup, not first line. Magnesium is your first line treatment. What are your priorities now, right? And how aggressively should we be treating the blood pressure? We want to control severe hypertension, but you don't want to tank a patient's blood pressure. I didn't include it here, given you already had a hypertension talk. But we have a similar kind of diagram workflow for management of severe hypertension in pregnancy, which involves IV antihypertensives to rapidly lower a patient's blood pressure. But we're talking over the series of 15 to 20 minutes between doses. We're not loading a patient up, right? The last thing we want to do with a postictal confused patient is also tank their blood pressure, make them somnolent, have low respirations, and also profoundly hypotensive. The biggest immediate risk to this patient is going to be recurrent seizures and airway compromise. So our final kind of take home on these 2 scenarios and on these 2 diseases, both of them have something in common. These are young, healthy patients who can crash really fast, but have treatable conditions if you act early. right? I'm not asking you guys to be the OB experts here, but I'm asking you to recognize these conditions early, do a few critical things for each of them, and move quickly to get the patient transported to where they need to be. Right. So if you remember nothing else from the postpartum hemorrhage section, heavy bleeding and shock is a postpartum hemorrhage. Assume it's uterine atony. Do your fundal massage. Give TXA, Pitocin if you have it, and transport the patient. This alone is going to be what saves the patient's life. If you remember one thing from the eclampsia section, a seizure in a patient who's pregnant or recently postpartum and hypertensive is eclampsia until proven otherwise. Magnesium is your first line treatment, and you're going to need to transport this patient fast. So I want to open it up to any questions that came up along the way, questions that you have pertaining to the topic, or any cases like this that you've seen in the field. I'd love to know what went well, what was challenging, how you might use some of these tools moving forward, and any other questions that may come up. I included my email here. Please feel free to jot this down. If you guys run into any patient-specific encounters over the next few weeks, next few months, or you have any questions, protocols that you're working to develop, please reach out to me. I'm more than happy to try and help answer any questions that you have and get everything kind of teed up for success for you all.
That's great. Thanks, Luke. We have a couple of questions that trickled in. One, let's see. Put them slightly out of order to kind of circle with the eclampsia things first. But one from Don was a question of no midazolam. I think your hospital workflow talked about using lorazepam, which for folks here, lorazepam is Ativan, midazolam is Versed. Answering from the EMS side here, the reason for this is a study that looked at some of the pharmacokinetics of midazolam versus lorazepam. And the reason EMS in the state of Maine has midazolam is the assumption is that for the average seizing patient, you're not going to have IV access. And so midazolam actually has a faster onset of action when given IM compared to when lorazepam or Ativan is given IM. If you have an IV in place, lorazepam has a faster onset of action than midazolam. So the reason Maine EMS goes with midazolam is assuming no IV access. Midazolam is going to be your faster onset of action. In hospital, the assumption is if you're hitting that level of we've already done magnesium and we're now getting lorazepam, the assumption is that you've probably established IV access at this point. So in the hospital, we tend to lean more onto the lorazepam side for the person who likely has IV access. So that is the benzo question. There was a question from John. I read a study years ago that said although positioning helps, all in all, it really doesn't work. Thoughts? And I think this was in reference to the left lateral, like what is the actual utility of putting someone on their side or not?
Yeah, that's a great question. I think it's one of those, I don't want to be too philosophical here by any means, but I think it's one of the thoughts of things we do potentially for no reason. I think it's from a physiologic standpoint, it makes good sense that a gravid uterus and a fetus is going to cause some level of aortic cable compression. And so anything we can do to just increase venous return, increase that cardiac output during one of these scenarios is going to be beneficial. It's as you are, you can imagine it's hard to do a lot of, randomized control trials and studies in pregnant patients to actually assess outcomes of a lot of these things. And so a lot of what we do in obstetrics and in the OB world is driven by kind of clinical gestalt and what we kind of assume is going to happen from a physiologic standpoint. It's a lot of outcome driven data. We can't really randomize someone to say, hey, the next 15 patients that you have with the seizure, you're going to tip half of them on their side, you're going to keep half of them supine, and let's see what happens. So to your point, from a seizure and aspiration risk management alone, you want to think about lateral decubitus positioning just to minimize aspiration risk. From an aortic cable decompression and increase in cardiac output and venous return, it likely plays some role, but what that role plays from a outcome standpoint is hard to say with any kind of certainty.
Great. The other question we've had so far was circling back to postpartum hemorrhage. The question from Craig was, what can a basic or advanced provider do if the placenta has not delivered and there's postpartum hemorrhage, assuming no fundal massage?
Yeah. So if the placenta is not yet delivered and you're already experiencing really heavy bleeding, one, you have to factor in kind of the time since delivery of the fetus. It's normal for the placenta to take up to 30 minutes to deliver. That's kind of within the normal range of what we consider the third stage of labor. Most of the bleeding from a postpartum hemorrhage is going to actually come from that placental bed, so kind of where it was attached to the uterine lining. So if the placenta hasn't delivered at all, then often, you're not going to be really encountering that much bleeding because that placental bed, that raw kind of those open raw vessels are not accessible and they're not, they're not going to be bleeding. So if you see significant bleeding at that point and the placenta is still in place, you want to think about some of your other T's. And often, that you're going to have a more extensive laceration from the delivery, whether that's a vaginal laceration or a cervical laceration as a kind of source of that bleeding. But if the placenta is still in place, you do still need to remove the placenta before you can really address that especially from a pre-hospital setting. And so, with respect to placental delivery, I just really wanted to stress that you're not putting fundal pressure, so you're not putting your hand on top of the uterus and pushing down to get that placenta delivered. Really, what you're doing is just kind of steady traction on the umbilical cord itself. If you've cross clamped the cord already and cut it, then you're just putting that kind of steady, gentle downward traction. With your other hand, you're putting it right behind the pubic bone, kind of right overlying the bladder, and actually trying to put your hand, at the bottom of the uterus, so kind of below the uterine fundus, so that as you're pulling that counter traction, you're not going to invert and pull the uterus down.
Great, thank you. I know Mark answered the question in the chat that yes, Lifelight does have magnesium. Mag, it's interesting. It's one of those drugs that it's worth exploring for those that are paramedic services, how much you're carrying with you. Because if you go through that workflow of if you need to give the initial 8 grams IM, then potentially redosing, and then potentially getting to a drip, you may find that the amount of mag that you carry in a single ambulance may not adequately meet that. So it's just something to think about if you are a longer distance transport service, a more rural service, to think about your preparedness to work through that algorithm. All right, do we have any other questions, folks? If so, feel free to drop them in either the chat or the Q&A. While we just give a minute, just thank you again, Luke, for being here. We do have one. Let's see. Beyond this class, what are your feelings for OB patients who are traumatically injured, fall, MVC otherwise, and should they go to a trauma center, which in the state of Maine, there are now only 2 designated trauma centers, being Portland and Bangor, versus going to your community or local ED?
Yeah, I think that's a loaded question. I think certainly the patient would be best served, coming as quickly as possible to a trauma center. But depending on the resources that you have to transport and get the patient stabilized, you just may not have the ability or the resources to do that. And so it may, mean that you're needing to go to your community or local ED to be able to access some of those resources prior to getting a patient to a trauma center. I don't want to pretend to know the nuances of the legal logistics of where you take a patient. But ultimately, yes, a patient would be best served after a trauma at a trauma center if possible. At the very least, at a facility that has, an obstetric care and provides obstetric care, which is becoming increasingly less common, especially in a lot of our rural locations. So, what you all are doing is admirable and becoming increasingly challenging from that standpoint. So, I think makes what you do that much harder. As a part of this, I'm happy to come back and talk more about any specific OB topics that come up or that you're seeing increasingly commonly in your communities, or that are rare but can have serious consequences in this way. So if there are other topics that you all want to hear from an obstetric standpoint or from a gynecologic standpoint, please make sure that you communicate that with Joe and Eric, and and kind of happy to come back and talk about some of those other topics.
Yeah, that's great. Yeah, I think from the EMS side of transport, I think it falls into many other categories of, VAD or pulmonary hypertension, like these specialty niche places that ultimately need to go to a certain place. If you're truly running into a patient with a VAD who has, critical traumatic injury and needs to be stabilized, like I would stop at the local or community ED, get transfusion, get stabilized, and then coordinate going to your specialty center. I think OB similarly, if you have a OB center that's roughly equidistant, but if you need to stop somewhere to stabilize, then you should stop to stabilize mom. Um, and then I think there was one other question mixed in here. Lorelei asks, how does the IM compare to IV? I'm assuming that means magnesium. Um, yeah.
Yeah, I'm gonna assuming you mean kind of reaching therapeutic target or therapeutic dosing, but it's fairly equivalent in terms of the initial loading dose from an intramuscular standpoint. Again, our goal is to try and get that patient between about 4 and 9 milligrams per deciliter of their circulating magnesium level, and so that what we often do in that inpatient setting is 10-gram dose total. But even an 8-gram dose is usually going to be sufficient to get that patient within that therapeutic target. We don't, if a patient has IV access, we certainly prefer that, just because getting 10 mLs in each glute is going to be pretty darn uncomfortable, especially in a patient who's postictal and is probably a little bit more with it in terms of how they'll feel and respond to that. But in terms of the therapeutic effect, it's actually fairly similar.
And reminder too for folks for the main EMS side, IO is also an option for you for your mag. So if you have that person that large volume, you're worried about trying to get more into an IM route but can't get IV access, IO is also an option for giving mag with similar efficacy through IO as well. I think that has covered all the questions. If I missed someone, please speak up. But yeah, to Luke's point too, as always, let us know what other topics you want to see in the future. As we look to trying to do things of more case focused reviews too. If you have interesting cases that you'd like to do kind of shared review and have an EMS perspective and also have a OBGYN perspective on and can do some discussing here, Luke is on board and willing to help. So let us know. We're always looking to make these better and make these useful for you all. So I think without further ado, I think we can let people go on their way and have a couple minutes of their day back. Luke, thank you again for being here. Really appreciate it.
Yeah, thank you all for having me, and I look forward to working with you all more and hearing from you guys more.
All right, take care, folks.